And let me just start talking from here onwards. So this is a mixed lesion where there is a mitral valve disorder and there is a aortic valve disorder too. Now, this is a typical situation where it's not unusual. All of us face this all the time. And if you look at this, there is a diastolic doming, the PML is fixed, and there is an aortic regurgitation. Now, aortic regurgitation, what it does, whether there is aortic regurgitation with or LV, without LV dysfunction, what it does is that it increases the left ventricular end diastolic pressure suddenly. If you look at what is happening in aortic stenosis and mitral stenosis is, understand that both are diastolic phenomena. In aortic regurgitation or in mitral stenosis, the blood comes into the ventricle in diastole when the heart is relaxing. And this is the reason why when you look at this here, you'll find that there is a mixing of the jet as it goes right across into the LV. Now, imagine that there is certain quantum of pressure in the tank in the left atrium, and there is certain quantum of pressure in the tank in the left ventricle. Now, if the pressure of the left ventricle increases, the difference between left atrial pressure and the left ventricular pressure in diastole will reduce. When this pressure reduces, what will happen? The pressure half time will fall. When pressure half time narrows, your valve area assessment is prolonged. And this is exactly what is happening in this case, because there is an increase of left ventricular end diastolic pressure for two reasons. One is that there is severe aortic stenosis, and second is there is aortic regurgitation. Both are contributing for increase of left ventricular end diastolic pressure. Now let's see this, where there is the LV dysfunction. Earlier there was no LV dysfunction. In this example, there is an LV dysfunction, and let's see what it manifests like. Here, if you look at this 2D picture, there is a LA, which is large, LV, which is poor. Mitral leaflets are thickened. In fact, the chordae are also thickened. There is a little bit of a lax chordae, but we are not going into those anatomical details. We are just talking about how one valve interplays with the other valve whenever there is a lesion. So if you look at this, there is a lesion here, lesion meaning that there is a leakage here. And if you look at the non-coaptation, area of non-coaptation is there, which means that there is a large, if you look at that, large area of vena contracta. Now, in a left ventricular end diastolic pressure, when it is high because of LV dysfunction, mitral regurgitation gets exaggerated. So how do you say that this mitral regurgitation is because of exaggeration, because of LV dysfunction or not? Fortunately, in this example, we have that the mitral is organically diseased. And what is the evidence of organical mitral involvement? The lesion is in the mitral valve primarily because A, there is a diastolic doming. Number two, diastolic doming for all practical purposes means stenosis. Number two, PML is fixed and the mitral valve apparatus is thickened, which includes that AML and PML both are thickened. Now let's see one more example at some point of time, and here, which is again, we'll assess the mitral and we'll see what it is. So this is somebody who has a fairly thin mitral valve apparatus, but we don't know because LV is a little poor. There is some kind of a LV apical clot or myocardial hematoma. Don't know. We are not going into that discussion, but let's see whether it is organic or non-organic and something should be done for this mitral valve or not. If you look at this, here comes the crux of the matter, that this is a significant mitral regurgitation. Now, serious issues occur when it is moderate. In a large kind of a vena contracta, which is close to about 4, we are looking at a significant mitral regurgitation may or may not be organic, but significant mitral regurgitation in LV dysfunction becomes a reason for getting intervention done for whatever reasons, especially non-surgical ones which have come into existence these days. Okay, now let's look at a few examples of aortic valve. So give you a little bit of a background about this girl. Again, this girl has had aortic valve stenosis in past, for which she had an aortic valve replacement in past, and now her aortic valve is showing pannus gradients. Don't know whether it was pannus or whether, obviously, if it is a slow growing this thing, it is pannus. And let's see and assess the mitral only. If you look at the aortic, you'll find that there is a posterior acoustic shadowing because she has had artificial valve, which is metallic variety. If you look at the mitral is thickened, it is showing diastolic doming, so it's a rheumatic mitral disease. The opening is kind of a fish mouth, not very good pictures, but if you look at this here, you will find that the aortic valve area is 1.2 by planimetry. Now, is this good enough? Is this not good enough? Can you trust this? Can you not trust this? So let's see more what it has to offer. Now, these are gradients across pulmonary valve. We don't need to really bother about it, except, and now you will be able to see that the mitral is really organic, diastolic doming of AML, PML is fixed, and the mean PG is 12. Now, mean PG 12 and mitral valve area of 1.4. This qualifies to be called as severe, despite the fact that there is a severe aortic stenosis because of pannus on an artificial valve. The problem would have been if the gradients would have been lesser or the mitral valve area would have been more than 1.5. So if you go by the current recommendations, any area, mitral valve area less than 1.5 is considered severe aortic stenosis, as against what it was a few years back when less than 1 was only considered as severe aortic stenosis. Why am I talking this? Because she in any case has to undergo aortic valve replacement. If you change this aortic valve without tackling the mitral valve, what are you going to do? The moment you reduce this gradients across the aortic valve, your gradients across mitral will further flourish. The moment you reduce the afterload, you take out this stenosed aortic valve, replace with a non-stenosed aortic valve, what are you going to do? You are reducing the left ventricular end diastolic pressure. The moment the left ventricular pressures fall, the gradients across mitral will increase. So it was very necessary that we had to take a call and took this lady for a redo double valve replacement. And this time what we did was that we gave her tissue valves because we were not too sure what the etiopathogenesis was, because when the surgeon took out the aortic valve, we had made a diagnosis of pannus, but he said that there was a pannus, but there was a lot of thrombus over it also. So we didn't want to land up with problems again, and we got her a double valve replacement. So these are very tricky issues where you can be stuck for life, because in case you don't change the mitral valve, you are stuck. You change the mitral valve, and in a redo double valve replacement, the risk of surgery is exorbitantly high. Single valve replacement, the surgical risk is lesser, but for a double valve replacement, especially redo, it's unacceptably high. But if you are sure that mitral gradients will increase after you take off the aortic and replace it with an almost normal valve, then you are comfortable making that decision at some point of time. Now, this is the importance of how you have to assess the hemodynamics, because patient care suffers if you don't look at it this. So here is the same patient's example where we had a T done and documented that the valve was stenoted significantly. Now let's assess the aortic valve. Now this is fairly a normal LV, and in this normal LV, if you look at this, you are looking at gradients across the aortic valve. Apical continuous wave aortic valve did not show very significant mean gradients, because if you look at this mean PG across aortic valve of 10 means non-significant, or it's a mild aortic stenosis. But the catch point is that when you looked at the earlier pictures, these earlier pictures showed that there was concentric LVH. Concentric LVH in a non-hypertensive patient with a thickened aortic valve, start suspecting that you are missing a severe aortic stenosis. And then you have to try some other tricks of the trade and start looking at epigastric, start looking at suprasternal, start looking at one of the views which I learned from Dr. Rakesh is the RAO, right anterior oblique view. Those are very interesting ones, but we looked at this from the right parasternal, and we found that the mean PG was 53. So fortunately, across the Atlantic, now it is all settled that any mean PG in aortic valve greater than 40 millimeters of mercury, you are comfortable to label it as a severe aortic stenosis. And when you calculated the aortic valve area, it turned out to be severe aortic stenosis. But this is the comparison of apical and right parasternal view, where you find that what has happened. Now, it is simple when the LV is normal. Problem comes when the LV is abnormal. So LV dysfunction interferes with valvular assessment very, very, very significantly. And this is one thing which I just wanted to show, that this is post CABG patients with severe LV dysfunction with recurrent hospitalization for heart failure. Now, we know, if you look at this parasternal long axis, LV is poor. There is tenting of the mitral. If you look at the aortic is thickened, calcific, posterior shadowing, some bit of aortic regurgitation. Now, if you want to see further, this is short axis, again, showing an extremely poor kind of contractility. When you look at the four chamber, the LV is lesser than 20% or maybe 20% or thereabout. There is a MAC, which is mitral annular calcification seen. Aortic valve assessment is very, very, very poor. Now let's see where are we as far as aortic valve assessment is concerned. This is parasternal which we saw. We were convinced that we are dealing with something which is bad. Now look at the short axis across aortic valve. This is too much of calcium, and this too much of calcium is something which precludes planimetry across aortic valve. What happens is, what are the things which you have to trust when you don't get gradient? You have to trust global longitudinal strain. You have to trust a few more things. And the most important is that if you get an area of this sort, 0.776, you don't know whether it is because of poor contractility that the valve is not opening and giving you a falsely low aortic valve area. So what you do, you kick it up, and you kick it up by doing a dobutamine stress echo. So this was the area which we got from our assessment at rest, which is aortic valve area of 1.1. And then we did a dobutamine stress echo. Now this was the baseline wall motion, few segments which were expected to be akinetic were akinetic, but rest of them were all hypokinesia. And this was the resting echo, that there was a mean PG of 15 with an ejection fraction of 20%, hugely dilated LV with AVA or continuity equation aortic valve area was 1.1. There was a little bit of mitral regurgitation. Now, do something or you don't do something. Now, the surgical risk for this patient is obnoxiously high. You take this person for surgical change of valve, and you're looking at a mortality of almost about 1/3. So 33% people will die. Now, we wanted to be sure, and unfortunately, when we did a transesophageal echo, we didn't find too many good pictures because, again, the shadowing was unacceptably high. These are certain pictures where we couldn't get very good analysis. So what we did was we did a few more tricks to sort out the issues. And what are these tricks that you have? So all these pictures in transesophageal echo were so poor that we couldn't make head or tail of aortic valve area. And we said that we are going to skip this and we are going to do something else. So we did some 3D constructions. But unfortunately, what happens is 3D is, if you don't get good 2D, you will not get good 3D. You rubbish in, you'll get rubbish out. So if you don't have good 2D pictures, you'll never get good 3D pictures. This is what happened. Now, how do you do rest? So we did a calcium scoring, and we did a calcium scoring for aortic valve. Now, if you look at the cutoff of units. If for men, if it is more than 2065, and for women, it is more than 1274, this favors severe aortic stenosis. But per se, this may not necessarily be the truth, because LV, aortic valve calcification could be there, even with open valve in cases like parathyroidism or CRF or whatever. So our men continue to have a very high calcium score across, but we continued with our quest to sort out what it is, and we did a dovitamin stress echo, only low dose. So when you do dovitamin stress echo low dose for a severe aortic stenosis, expectedly severe aortic stenosis, poor LV, low gradient, low flow, then you want to see what all? You want to see fall of aortic valve area, and you want to see increase of gradients. So this is what we attempted to do, and this is what we did. And when this is the baseline mean PG was low and aortic valve area was low. And when we did, this is the aortic valve area which we calculated 1.1, which is not, which does not conform to severe aortic stenosis for all practical purposes. We did a low dose dovitamin stress echo, and when we did that, we found that the aortic valve area dropped from 1.1 to 0.76 and 0.71, and the gradients increased from 15 to 29. Now, this is some place where then we thought that, yes, now we have assessed our aortic valve, and we were now justified to suggest a valve replacement. Now, what valve replacement? Because surgical mortality was so unacceptably high, we got this person TAVR, and post TAVR, expectedly, the LV functions improved. Now, these are my own assessments. Now, in LV dysfunction, this is a very dogmatic statement which I'm making, but in any LV dysfunction, all left-sided lesions are underestimated, except MR. Why? When there is LV dysfunction, in mitral stenosis, I have said that the pressure half time shortens. Pressure half time shortens because the pressure difference between LA and left ventricle in diastole shortens. When the gradient shortens, the pressure half time shortens. Pressure half time shortens, mitral valve area increases. So in mitral stenosis, you overestimate the area and underestimate the stenosis. Now comes the aortic stenosis. When it comes to aortic stenosis, the contractility is reduced. When contractility is reduced, the cardiac output reduces. When the cardiac output reduces, expectedly the gradients across aortic valve fall. And then you get falsely low gradients, and you assume that there is no significant aortic stenosis. So again, aortic stenosis is also underestimated. Now, what about aortic regurgitation? In aortic regurgitation, what happens is that this is a diastolic phenomenon. That means when the LV is expanding, it is sucking blood from aorta into the LV. But what if the pressure of the left ventricle is high? When the pressure of the left ventricle is high, it prevents the suck down effect from aorta to LV because the pressure causes a dampening phenomena and the aortic regurgitation is again lesser. So this high diastolic pressure prevents aortic regurgitation to manifest or to enter into aorta, and that causes a problem. Problem comes with MR. LV dysfunction and MR is a different ballgame altogether. At some point of time, we are going to talk about primary and secondary mitral regurgitation, but there are two reasons why mitral regurgitation worsens. One is that LA pressures increase, and these LA pressures transmit to pulmonary valve, and over a period of time, the moment the LA starts to increase in size, it stretches the aortic valve, the atrioventricular ring, and this expansion of our atrioventricular ring leads to non-compact discontinuity, and it leads to leakage of the mitral regurgitation. Now, this area of leakage is what I said just now was because of vena contracta, which is the 2D manifestation of vena contracta, and this area of non-coaptation should always be seen with area of suspect, and that is the time when denting areas, etc., needs to be calculated. But in LV dysfunction, so the first thing which you do when you see a mixed lesion or a single lesion or otherwise, assess the LV functions. The moment there is an LV dysfunction, understand that except for mitral regurgitation, you can be underestimating, and mitral regurgitation, you could be overestimating. Now comes the problem that what to trust when you have to assess. So if in LV dysfunction or otherwise also, whenever there is interaction between two valves, in mitral stenosis, if you have to trust something, close your eyes and trust planimetry. If you have 3D, it is a little better because in 3D exactly you know that which is the narrowest area of the funnel that you cut across. Otherwise, you can overestimate the mitral valve area because anything other than the narrowest area, you planimeter and you'll be overestimating mitral valve area. But in a 3D, you can really see the funnel, you can cut across and you can planimeter it. And that's the reason why for mitral stenosis, close your eyes and planimetry becomes the best way. So these are some rules of thumb which may not entirely be truthful in every patient, but these are good working rules as what I have understood in these many years. For mitral regurgitation, vena contracta is a very robust phenomenon. For aortic regurgitation, you'd be surprised what I'm going to say. If there is a large pulse pressure, trust BP. If there is a narrow pulse pressure, you can't really say that there is no aortic regurgitation. But if you have a large pulse pressure, then blood pressure becomes a very good tool to make you understand that hunt for AR, hunt for AR, hunt for AR. Now in AS, you have to have a high index of suspicion the moment you see a calcified aortic valve. And that is the time, use low dose dobutamine and don't hesitate to use multimodality, and calcium scoring is very useful in these cases. So these are the pearls of wisdom as what I can make out, and let me make myself assessed now that whatever I have talked, has it percolated some bit for all of you or not? I'm going to give you 4 or 5 situations where there is only mitral stenosis with other lesions. So if true mitral valve area is 1 centimeter square, true mitral valve area or surgical mitral valve area is 1 centimeter square. in a severe MR, when you do pressure half time, what will it show? Area of 1, area of 1.3, area of 0.8, or none of the above? Please unmute yourself and let me have uh, the answers from the house. Then I'll go for other this thing. Hello.
Yeah, anybody can unmute himself and answer this question. Let's have a vague answer also. Let's try to understand this important issue. Samir, I think you'll have to only explain about all this.
Okay. So what happens is that there is mitral regurgitation and there is mitral stenosis. So area of mitral valve is 1. And what happens when you do pressure half time? LA is receiving blood from pulmonary veins, and in systole, LA is receiving blood from mitral regurgitation from LV also. So if there was some quantum of blood in LA, say X, when it receives from two places, pulmonary veins and from the left ventricle, it becomes 2X. So LA has received 2 times or maybe more of blood as what its capacity is. And when there is diastole, it has to go through a narrowed path. So what will it take? It will take a longer time. When it will take a longer time for the large quantum of volume to flow through the mitral valve, you will have a large or a bigger pressure half time. Bigger pressure half time means that area will be a true area which is supposed to be 1 in a severe MR with mitral stenosis. Pressure half time will record it as 0.8. I'll give you another example to find out whether we are on the same page or not. Question remains the same. And this we have already sorted out and we have talked that the true mitral valve area is 1 centimeter square. Now what happens is there is severe aortic stenosis. What will pressure half time show? Area of 1, area of 1.3, area of 0.8, or none of the above. So what is happening in earlier in mitral regurgitation, there was a volume overloaded situation from LA. It had to pass through the narrowed orifice. Now, instead of volume, we are playing the pressure game. This pressure game is because in severe aortic stenosis, the left ventricular end diastolic pressure increases. When left ventricular end diastolic pressure increases, the LA to LV pressure difference falls. When LA to LV pressure difference falls, the pressure half time falls. When pressure half time falls, the valve area instead of 1 will become 1.3. Larger pressure half time means smaller area. Smaller pressure half time means larger area. So this is in severe aortic stenosis and mitral stenosis. If you look at the pressure difference fall, it will be lesser because the gradients are lesser, not because the valve is lesser stenosed, but because the pressure difference games are such that with aortic stenosis, the ventricular pressures goes up and thereby reduces the difference between LA and LV pressures. Okay, so one more example. Question remains the same. True mitral valve area is 1 and the patient has atrial septal defect. What will pressure half time assessment of valve area will be? 1, 1.3, 0.8, or none of the above? So I'll sort it out before shooting it out to everybody else. Now imagine there is some quantum of blood which comes to LA. say X. But instead of flowing all through the mitral valve, half of it flows through. And this is a mathematical model to make things understand. It may not be the truth, because depending upon what the size of the shunt is, if it is 2:1 shunt, 3:1 shunt, there's so if some quantum of blood comes into LA, instead of all of it going into mitral, some bit goes into RA. So what is the quantum of blood which has to pass through mitral valve? It was only half. If it is only half, it will take much lesser time. If it will take much lesser time, the pressure half time will fall. If the pressure half time will fall, mitral valve area instead of 1 will be 1.3. Smaller pressure half time will be larger area, less stenosis. Larger pressure half time will be less area, severe stenosis. Okay. One more. What happens in severe AR? We have discussed some bit of it, but severe AR is a little bit of a tricky situation. If the jet is central, a central jet will always increase the pressure half time, will decrease the pressure half time, because there is a sudden increase of left ventricular end diastolic pressure. But in severe AR, if it is not a central jet and the jet is hitting the anteromitral leaflet several times, it prevents opening of the mitral valve in diastole, because jet of AR prevents opening of the anteromitral leaflet. And when that happens, you can have either 0.8 or 1.3, depending upon whether the jet is central. If the jet is central, you'll get 1.3. If the jet is eccentric and hitting the AML to open it up, when you look at it, it may be 0.8. So I am going to give you one valve, and let's see whether we can make some sense of it. In this, I would certainly want people to give me inputs. What is this lesion? Which is the valve? And quantify the valve and let me know what the sense of it is. Unmute yourself. Let everybody give an opinion.
It's sir, it's AR jet, and it looks like mild AR.
And next, so that
this is a significant there's a significant AR because aortic root is also dilated.
that's Dr. Bhatt speaking.
Yes, sir.
Dr. Bhatt says it is significant
because because there's root dilatation also simultaneously happening over there.
Okay.
Aortic root is also dilated.
Okay.
Because of that, there's a dilatation over there.
Anybody else?
I would say moderate.
Moderate AR?
Yeah.
Anybody else? Anybody else? So this is the Doppler pattern across. Okay, so this is not reading. I'll go back again into the earlier slide so that we discuss what it is. So Dr. Bhatt, which phase is aortic regurgitation seen in? And in which phase is the aortic regurgitation leaking here? Let me see if it plays once again, because this is a color Doppler. No, it doesn't play. Okay, doesn't matter. So here, if you look at this, this is actually an aortic regurgitation which is occurring both in systole and diastole. How can aortic regurgitation occur in systole? This is a big question here. So let me let the cat out of the bag. Otherwise, we'll keep getting delayed unnecessarily. If you look at this apex, there is something which is a very metallic shadow here. So this is a person who has got a LV assist device. LV assist devices are given for poor LVs these days, where this is apparatus, which is the outflow. This sucks the blood from the LV, and there is an inflow which is there in the ascending aorta, which you can't see here because this is done at ascending aorta level just below the subclavian and brachiocephalic. And this is the place where they have injected it. Now this is running through a continuous motor. And this continuous motor is such that it sucks in the blood from LV, pushes it into aorta. And if you have an aortic regurgitation, it will keep showing in systole and diastole. So I'll close my talk here, and I appreciate all the patience and you tolerated me so much today, because despite the internet connection and everything, but I just hope it was useful to everybody. I'd be happy to take any questions in case there are any, and I'll